This is an artist's rendition of the anatomy of Dupuytren's contracture. This is Dr. Frank Netter's artistic rendition of the anatomy of the palm of the hand. Here you can see that the skin has been removed from the palmar surface of the hand, and you can see the palmar fascia, which starts as the palmaris longus tendon, and as it courses distally into the fingers, it becomes a palmar aponeurosis. It's this palmar aponeurosis that becomes thickened and contracted in Dupuytren's disease. The palmar aponeurosis thickens and contracts the finger, and this becomes Dupuytren's disease. It's this fascia that we remove or excise in treatment of Dupuytren's. Here's the palmar surface of the hand of a patient with Dupuytren's contracture, and you can see the typical cord present along the palmar surface of the hand. As we extend the fingers, the cord becomes more prominent. I'm using a marking pen here to outline incisions for removal of the diseased tissue in this patient with Dupuytren's contracture. Remember that Dupuytren's contracture is a progressive disease. The surgery is designed to remove the diseased tissue that's present at that particular moment in time, but studies have shown that 50% of patients over the course of 10 years will have either a recurrence or an extension of the disease into other areas. So surgery is not curing the disease, it's removing the contracted tissue that's present at that particular moment in time. It's designed to relieve or remove a contracture. The incision has been made, and we have exposed the pathologic cord that you can see leading into the small finger. The cord contracts, preventing the finger from extending. It thickens as well as pulls the finger down into flexion. Almost like a banjo string. Here's the cord to the ring finger, which has also contracted in this patient. We remove these cords to eliminate the contracture. This is the typical cord that you see in Dupuytren's. Here, we're cutting the cord, which relieves the contracture and allows the small finger to come into full extension. Here the cords have been completely removed, and you can see that the fingers are into full extension at this point. All diseased tissue has been removed. Following wound closure, we leave certain sections of the palm open. This prevents hematoma accumulation or excessive blood, and these gaps in the skin will close in about 3 weeks. We operate under tourniquet so that we don't see any bleeding during our dissection. This same patient is seen 6 days following fasciactomy for Dupuytren's. Typically, between 3 and 6 days following surgery, we remove the dressings and start gentle active range of motion, as you see here. The wrist wound that you see in this patient was for an additional surgery unrelated to Dupuytren's. Sutures are typically removed 2 weeks after surgery. The open palmar wound is typically sealed in 3 weeks, and at that point we transition patients back to normal activity as tolerated. Collagenase injection is another option instead of having surgery. Collagenase is an enzyme that dissolves the Dupuytren's cord. This is an enzyme that is injected in the office without having to go to an operating room to undergo surgery. We prep the skin with betadine and then spray the skin with ethyl chloride, and here you see us injecting the enzyme directly into the cord. The enzyme dissolves the Dupuytren's cord without having to undergo surgery. This is a compound that is produced by the Auxilium Corporation. Collagenase is also known by its brand name Xiaflex. The Dupuytren's cord is typically injected in 2 or 3 different locations through 2 or 3 separate needle tracks in the office. We then return the patient to the office the following day for manipulation. This is the same patient now 1 day following Xiaflex collagenase injection, and we are gently manipulating the patient's finger into full extension and rupturing the cord. You can see that in many cases you can get a significant amount of black and blue discoloration and swelling as a result of the injection. Collagenase is a chemical fasciactomy, so it's dissolving tissue, and it's also, in many cases, causing somewhat of a chemical reaction which can produce swelling and discomfort. We're basically pulling the finger into full extension and rupturing the cord. Some patients elect to have local anesthetic blocking the finger prior to manipulation. Here he is 11 weeks following collagenase treatment. The average patient needs 1.5 collagenase injections per cord, so an occasional patient will require a second injection to completely eliminate a single cord.